Okay, morning everyone. For those of you who don't know me, I'm Dr. Tracey. I'm one of the physicians that work in internal medicine department. Today I'll be talking about the antibiotic guidelines. Just a raise of hand in the crowd. Who's here from animal health? Raise of hand. Good. Agriculture sector? Same. Okay. And those from human health, raise of hands. Just a handful. Okay. So today I'll be talking about the Fiji antibiotic guideline that was launched and was released in 2019. And so this is basically more towards human health. So for the others in the different sector, I'm really sorry if you're going to get bored with the presentation. But please just bear with me in the next half an hour or so. First of all, I'd like to acknowledge Professor Jenny. This PowerPoint actually belongs to him, and he was one of the main contributors who wrote up the antibiotic guideline. Most of the guideline, the last guideline we had was in 2011, and each guideline you have to review it every 5 years. And then most of our resources that we use our neighboring country, which was Australia. The working group of this antibiotic guideline is mostly from the private sector, the public sector. We also involve the pharmacists and the different specialities that exist. So these are some people that were acknowledged who played a major role in writing this guideline up. And you see that person in the middle, that's Professor Jenny. I'm not sure if maybe the hospital staff would know him. He usually comes here and he's very passionate about antimicrobial resistance. And he's actually an ID physician and a microbiologist in Melbourne. So all the guidelines, when they wrote the antibiotic guideline, they had to keep it in line with the other different guidelines that exist. So all of us here sitting in the room from Human Health, how many of you have the antibiotic guideline downloaded on your smartphone? Raise of hand. 1, 2. Only 2? Okay. So before, when we started off work, we used to carry all these little tiny booklets and put it in our bag and run up and down the hospital and refer to these tiny booklets. But this day and age, everything is digital, and you can download this on Google Play for those who have Android phones, and you can download this Fiji Host app. So it has all the guidelines in Fiji. So they include most of, and the host also includes the Fiji Essential Medicine list. And what are we're here today because the whole reason of having the guideline is because we have antimicrobial resistance, and stewardship is to mandate that there's responsible antibiotic prescription worldwide. Yeah? And the reason why we're sitting here today and this whole week about AMR awareness is because of us, consumers in hospital, consumers in agriculture or in animal consumption. We all use antibiotics. And when we misuse and overuse, and this is how the microbes develop resistance. And now we're sitting here today because now the microbes are getting smarter, it's developing resistance, and we don't have many antibiotics options now, like what Reno mentioned about, because they're not able to make profits. There's no point making an antibiotic when there's going to be resistance and no one's going to purchase such antibiotics that's not going to work against infection. So if you look through your Fiji Host app, those antibiotics that is not on the essential medicine list, they have a superscript on the top. So why are we here today? It's actually 413 pages, and this slides is only up to 136. So I'm going to skip through some slides that are quite dense and that the more important ones I'll focus on. So there's actually 19 chapters. Just a bit of introduction to antimicrobial. Then we have the cephalosporins, which were first generation. It has good, excellent cover against gram-positive organisms such as staph and strep. And we usually use this for those who have skin and soft tissue infection. This has replaced caplothin, which was in the old guideline. So WHO have their list of essential medicine. Clindamycin is now replaced the erythromycin in the older guidelines in 2011. It has excellent gram-positive cover, especially Staphylococcus. However, it doesn't have any gram-negative cover and an excellent anaerobic cover. So, have any one of you seen augmentin on the drug charts in the ward? Yes or no? Right. So usually before they used to prescribe amoxicillin, and because of antibiotic resistance, these microbes, they produce this enzyme called beta-lactamase. And so what this enzyme does, it breaks down the beta-lactam ring of this group of antibiotics. And to encounter this, they made a combination with a clovenic acid. That's how you so amoxicillin plus clovenic acid equivalents to augmentin. So this is just to cover for those who microorganisms that produce beta-lactamase. So usually you can give this for gram-positive organisms, Staphylococcus, but not your MRSAs. And it's also on the WHO model list that was published in 2017. I'll just skip through the slides and I'll just talk on the important ones. Okay, have anyone had any allergies to penicillin? Raise of hand in the room. Have taken penicillin and they had allergic reaction? Nobody. So everyone is safe to take penicillin. But there are some cases, some people have allergic reaction, and some of this allergic reaction is like they can get itchy skin, shortness of breath, swollen eyes. And because of that, we have different options. So if you're allergic to penicillin, there's different groups of antibiotics that you can use. So in your Fiji Host app, you can actually check if you're allergic to penicillin, what's your next option? So some can be non-severe, just like a rash, it's itchy. But those who become really, really severe reactions, some people's skin actually falls off. And this is a toxic epidermal necrolysis. I'm not sure if anyone sitting in the room have seen it, but I've seen one when I was a medical student. She took some antibiotics and her skin just shed off like as if she was like you know how the reptiles shed their skin? So that's what happens. So this is the beta-lactam I was referring to. So this is your beta-lactam ring. Chemistry. So the beta-lactams, it includes penicillin and cephalosporin. All right. So if you have group A strep, you can give benzathine, penicillin, IMI. So the nurses here in the room, benzathine, what's the color when you mix it or when you administer it? Is it clear or is it blue, purple, red? It's a milky. And make sure these ones are only given IM. You do not give this IV, otherwise you can cause a reaction. Okay, for the surgeons, I'm not sure if there's any surgeon in the room, but when you do surgeries, there's a prophylaxis that you give before you actually cut the patient. And if your surgery goes for long, you give it at intervals. But it should not continue after surgery, more than 24 hours. Okay, endocarditis. Did we invite any dentists here today? Okay, no. All right, so in Fiji, has anyone heard of rheumatic heart disease for those not in the human health? It's usually publicized in the newspaper, radio. Right, so rheumatic heart disease is when you have a strep infection that usually causes sore throat or skin sores. And so the antigen of this bacteria is very similar to the heart. So when the immune system, the white blood cells tries to fight off the bacteria, they don't know which one is the heart valves and which one is the bacteria. So it attacks everything. And that's how they damage the valves in the heart. And that's how this is usually seen in younger kids. They actually develop rheumatic heart disease. So if you have a child who has rheumatic heart disease and they're going to the dentist, that's one of the requirements. They must get prophylaxis. They must receive at least a penicillin dose. Yeah? And there are other conditions like congenital heart disease that's not repaired, or those who have previous history of infective endocarditis. And when you look in the Fiji Host app, there's a table which clearly outlines the specific dental procedures that needs prophylaxis and those who don't need prophylaxis. And this is found on page 56. So if you're just going for oral checkup, you don't need to get antibiotic prophylaxis, or if they're going to just use anesthetic gel, you don't need prophylaxis. It's only those who need extractions and all. So the basics of giving this antibiotic prophylaxis is to prevent you from developing infection of the heart valves, which we call infective endocarditis. Sad. So do you guys remember when we had the meningococcal outbreak in Fiji? What year was that? 2018. Right, 2018. And do you guys know which strain was that? There's B, C, W, and D. So it was men C. Yeah? So sometimes like who are at risk of getting, when you have a meningococcal outbreak, who are at risk? Kids, those in close contact, school, hostel, prison. So if you have an outbreak, and it's usually in your nasopharyngeal. So for example, if I turn out positive with meningococcus, those who come in close contact with me, who live within the same household, they need to get prophylaxis so that they do not get sick. Or for those nurses or doctors who are involved with the airway, they come close in contact with the mouth and the nose, you need to go on prophylaxis as well. And also Haemophilus influenza type B, which causes meningitis. In the guideline, page 63 to 64, it specifically says who are the close contacts and who need to go on prophylaxis, and those who have invasive group A strep infection. So there's certain organs in our body that protects us from infection, and one of that is the spleen. So for example, if you lose your spleen for a medical condition, or if there's a motor vehicle accident, or you fell off a tree and you have a splenic rupture and they need to remove your spleen, those who have no spleen have to go on prophylaxis to protect themselves, especially against the encapsulated organisms. And they will have to be on amoxicillin 250 daily for the rest of their life. Besides the vaccine, they need to get 2 weeks before their splenectomy, removing the spleen. The other thing is those who have cirrhosis. So cirrhosis is just the liver. You have chronic liver disease and your liver gets shrunken, and you have high risk of bleeding in the stomach. Those who come up with upper GI bleeding, like they're vomiting blood or they pass out black stool, they need to go on prophylaxis as well, which is ceftriaxone, until the bleeding stops. And sometimes with chronic liver disease, what happened? Have you seen some people with big tummies? Yes. Yes, and that's what we call ascites. So ascites is the fluid in the peritoneal fluid, and when the bacteria grows in your peritoneal fluid, that's what we call spontaneous bacterial peritonitis. And so they'll have to go on antibiotic prophylaxis to prevent this infection in the peritoneal fluid. The other one to consider for prophylaxis is PJP. This is usually for people who are immunosuppressed, like those who are on prednisone more than 20 milligram for more than a month, or for our HIV cases. So they'll have to go on Ceftriaxone, 960 milligram OD. Okay, post-exposure. So some of us can get exposed. So bloodborne viruses, you have your Hep B, your Hep C, and HIV. So for example, you guys working in the agriculture field and you're working and then you get injured with a needle in the ground, you're not too sure whether it was infected with blood or not. You can always go to the SDI hub. We have our different protocols to follow. So most of us, when we go into the medical field, we have to get our vaccination for hepatitis B. And I think everyone sitting in this room, I'm sure our parents must have taken us to baby clinic. In the baby clinic, there's an immunization schedule where you have to, you get your hepatitis B vaccination. So if some of you have taken your bloods and you know that you have hepatitis B antibodies, then you know that you're immune, that you're not going to get it. But if you don't know your immune status, and if you, for example, I'm taking bloods from someone and I find out he has Hep B, and I don't know whether I've got antibodies or not, the first thing you must do is quickly get your Hep B vaccination and also get your Hep B immunoglobulins within 72 hours. Yeah? For Hep C, there's no prophylaxis. And for example, if any of us get a needle stick injury and the person is infected with HIV, that's what we call PrEP, post-exposure prophylaxis. You'll have to go on antiretroviral drugs for at least 28 days so that you don't get infected. So you reduce your probability of getting HIV. So for OBS case, any obstetric nurses in the field? Oh, I can see some midwives here. Good. So with the females, our vaginal tract, some of us are colonized with streptococcus. And overseas, when they do antenatal clinic, they actually do rectal swab and vaginal swab to see if group B strep exists. And if group B strep is growing, these mothers, when they go into labor or if they rupture their membrane, they have to go on antibiotics. So premature rupture membrane is like, how many mothers in the room? Raise your hands. Only a few? Okay. How many of you guys ruptured your membrane before coming to hospital? Water bag, broke your water bag. Right, so so that protects your baby, the amniotic fluid. So once you break your water, then your baby gets exposed to the bacteria and can get sick. So those who rupture your membrane, there's a protocol to follow to cover the mom with antibiotics so that you don't get sick and also your baby doesn't get sick. And sometimes when you deliver, you might get a 3rd or 4th degree perineal tear, which means it can extend right up to your rectum. And there are certain antibiotics that you must give for these ladies who go for repair. Okay, so I'm sure most of us have had a loved one or family member or a friend who's gotten really sick with infection and had to come to hospital. So the early recognition of someone with sepsis, whether you've got an altered mental state, like you're confused, tachypnea. I'll try to explain the medical terms so that everyone in the room can understand. Tachypnea is when you start to breathe very fast. Tachycardia is when your heart starts to beat fast. And hypotension is when your blood pressure starts to drop. And there's fever. When you have some of these signs, it's signs that you've got sepsis. And the first thing, once you present to a health facility, we have to initiate within 1 hour to give antibiotics. We have to recognize these signs and give antibiotics because this is going to save somebody's life. And if possible, you take sets of blood culture before you initiate the antibiotics. So in Fiji, we have a lot of cases of Staphylococcus aureus. This is a gram-positive cocci, which is in clusters. So when you look under the microscope, they look like grapes. It's actually a Greek name for grapes, golden grapes. Aureus, I think, is gold. So when you look under the microscope, it looks like grapes. And usually we give Cloxa to this for this Staphylococcus aureus. But some of the Staphylococcus aureus, they're resistant to Cloxa. So then we step them up to a different antibiotic. Anyone knows the name of that antibiotic? Vancomycin. Excellent. Okay, gentamicin is one of the aminoglycoside antibiotic. It's nephrotoxic and it also can cause hearing impairment. So make sure before we see people just injecting, pushing. You have to put it in an infusion and let it run so you don't develop these side effects. So an average person, 70 kilos, I'm not sure who they're referring to, but in the Pacific, we have all different kind of BMIs, but the maximum you can give up to, so it's 45 milligram per kilo, and you can go as high as 480. Vancomycin is for those staphylococcus that's resistant to cloxacillin, so you can give a loading dose. Okay, nurses in the room, how do you give vancomycin? Do you push or you give in a slow infusion? Okay, why? Do you know why? No, or we just know, okay, the protocol says slow infusion. Because if you rush it, they'll go into red man syndrome. So they'll become all red and they can even suddenly collapse and die. So make sure, always give it in an infusion. Right. In Fiji, cyclone is coming up. What are some of the diseases we start to see after a cyclone? Lepto, good. What else? Dengue, what else? Typhoid. So after cyclone season, you see someone who comes with a febrile illness, your mind starts to think, could this be lepto, typhoid, or dengue? But dengue, you don't give antibiotics, please. It's a virus. It's for typhoid and lepto, we give ceftriaxone to these cases. And I know before this guideline was made, we used to write ceftriaxone, 1 gram BD, and the nurses have to mix, give in the morning, then the afternoon. But now you can just give 2 grams once a day. It makes it easier for the nurses as well. Okay, I talked about MRSA already. And MROs, I think I can see someone from the lab here. So we're starting to have multi-resistant organisms. So when we say someone is multi-resistant organisms, they're actually resistant to at least 2 to 3 groups of the classes of antibiotics. And the ones we're seeing now is what we call ESBL producing organisms. It's extended spectrum beta-lactamases. So these are usually the gram negatives. And these gram negatives actually exist in our gut, the E. coli and the other gram negatives. And what we've been noticing that some of our patients or some of our relatives and friends who go overseas to the other Asian countries, when they go there for the medical treatment, they actually come back. Some of them bring in these MROs. Yeah? Okay, we've talked about Staphylococcus, MSSA. So if you have someone with Staphylococcus aureus, this is the bacteria that usually cause abscesses on the skin, even in the throat, in the muscle. It can even go sit into your lungs, even go to your brain. And I've seen a case it's so bad, it went from his bone and even he lost his eye as well. Eh? So this is something that we should treat with respect. It's one of those very dangerous bacteria. So sometimes some of us think, oh, it's just a little boil. Yeah. But you have to remember some of these little abscess can become complicated. So once you have someone with Staphylococcus aureus, usually we do a blood culture. We treat them with cloxacillin at a high dose every 4 hours, and then we repeat a blood culture. If it's negative, then we count 14 days from the negative blood culture, then we complete our treatment. The other cases where we continue longer for 6 weeks is, anyone knows a complicated staph infection? We go on for 6 weeks. Anyone from cardiac in the room? Lani? Complicated staph you see in cardiac nursing? Sister Shami? Well, sort of RHD, they are the risk factors. Those who have infective endocarditis. So these ones go for at least 6 weeks. So you make sure you treat the infection. Because if you don't treat it well, it can actually go and sit into the brain and cause strokes. So what you think is just a small, tiny abscess, it actually can become complicated and lead to very serious illness. Eh? Then we have a strep pyogenes, which is sensitive to benzyl penicillin. Okay, benzyl penicillin, when you mix it, what color is the fluid? It's clear. So you need to know the difference between your benza and your benzyl. Yeah? Okay, respiratory tract infection. I'm sure some of us have had or most of us sitting in this room must have had respiratory tract infection. When you have when you cough, it's productive and mucus. And do all of us get admitted or not? So who needs to get admitted? The very, very sick ones, those who develop pneumonia, complicated pneumonia, and there's different scores here. It's a COB and the SMART COB. And this is what the doctors do. They make a score and decide, is this patient sick enough to be admitted, number one? Is this patient sick enough, needs to go to ICU and need ventilation support? So if you just have mild community-acquired pneumonia, which is usually caused by Sanjani, which is the most common cause of pneumonia? Since you're from the lab, you would like to educate us. The bacteria that causes pneumonia, the common one. Good, streptococcus. So we can just give them amoxicillin, which they're sensitive to. And doxycycline is for atypical cover. They don't need to be admitted, but those who are moderate and severe, then those ones need to be admitted. Okay, bronchiectasis. Have you had anyone in your village, or if you know of someone who's always coughing a lot and they cough very thick, foul smelly sputum, and they can even fill up a bucket? Does anyone know anyone? No? What about the nurses in the wards? Yes. Right. So these ones here, you only treat them if there's evidence of active infection. Otherwise, you don't need to treat them because they're always going to be producing those foul-smelling sputum. Okay, in chapter 8, they cover the different types of eye infection. And then we have the CNS infection, the one we worry about, especially in our children. That's why we have the immunization schedule where we vaccinate our kids. There's the HEEP. They also get the pneumococcal vaccination so that they prevent them from getting meningitis. And because our vaccine, a lot of children's lives are saved. Who's from PEDS here? Anyone from PEDS? No? Okay, so it's very important. Those who have kids, to make sure you take your babies for baby clinic and make sure they get their vaccination on time. And for adults, there's Listeria monocytogenes. So these adults, if they get meningitis, we usually cover them with ampicillin. So if anyone comes with meningitis, if you suspect, start the antibiotics within 1 hour. You can and take your blood culture. If you can't take a CSF, which is putting a needle in the spinal cord and taking some fluid, that's okay, as long as you start the antibiotics first, because that's what's going to save the person. All right, so I talked about a little bit of infective endocarditis. So you must take at least 3 sets of blood culture. And then you perform an echo, and there's different things that you can look at the echo. So echo is like the scan of the heart. Sometimes you can see an abscess at the root of the heart, or you can see some vegetations or things oscillating in the heart scan. So these are the ones you have to really, really treat properly in 4 to 6 weeks. Sometimes some people admitted with infective endocarditis, they just want to go home, and nobody wants to stay in the hospital for so long. But we have to convince them, if you don't treat this properly, we can develop complications later. And in our society, rheumatic heart disease, we are one of the countries that is quite prevalent. So if anyone has a sore throat, your small kid, make sure you go and be seen by the doctor and you get your strep antibiotics. So this just talks about infective endocarditis, the different antibiotics that you use, which is benzyl penicillin, Cloxa, and your gentamicin. Remember, gentamicin is nephrotoxic, so we should always monitor the renal functions. And then we talk about the intra-abdominal infections. How many of us has, okay, I think everyone here in this room has had diarrhea in their life, right? Yes. Okay, what's the definition of diarrhea? Yeah, loose. Yeah, any loose stool more than 3 times. But not all diarrhea is caused by bacteria. Some can be virus, some can be parasites, and some can be bacteria. So not everyone with diarrhea needs to have antibiotics. Okay. Liver abscess. Who loves drinking grog here? Put your hand up. Right. That's good. We have to be honest with each other. So the thing is with drinking grog, there's this amoeba that likes to what's this? They're usually found in grog water, and when you share and when this infection goes into your liver, you can develop an abscess. And usually we give metronidazole for those who develop liver abscess. And because this amoeba have different stages, sometimes when we give metronidazole, it actually doesn't kill it off. There's some cyst. But I'm not too sure if we have paramomycin here, but this is the one that actually kills off the cyst, so you can actually get rid of the infection. So usually the total duration is unknown, but often you can cover them at least 4 to 6 weeks. And just like I had said earlier, most diarrheal illness does not require antibiotics. So if you're having diarrhea, please don't go and ask your doctors for antibiotics. You let your doctor assess you, they look at what's the probability it might be bacterial, then they will cover you with antibiotics. So after cyclone, we talked about Salmonella typhi. That's what causes typhoid fever. So how does Salmonella typhi spread? Let's ask the people in agriculture and animal health. How would you get typhoid? Okay, we'll ask one of the NPs to help. Yeah, so it's fecal oral. So you go to the toilet, you don't wash your hands properly, you go touch the food, the water, and whoever eats after you, they can get typhoid. And so, and it's usually those who's at home doing the cooking. Yeah? So the first case they found was Typhoid Mary. She was a cook in, I think, England. And they noticed everyone who goes to the restaurant where she cooks, they were getting typhoid. And they tried to catch her and tell her like to stop because she was still, so what happens with typhoid? It harbors in your gallbladder. So that means you can still be a carrier. So when you pass your stool and all, this Salmonella typhi is actually shedding in your stool. And so she didn't want to stop. So she went to another place, and then she was a cook there. And then when, for public health reasons, she actually had to put her in jail. But now public health is very different now. We got antibiotics that can actually clear up the Salmonella typhi in your body. And this is what we call ciprofloxacin. So if anyone here has had a typhoid before, usually after you are treated, we always explain to you about your hand hygiene, which is important. And then that's after going to toilet, before you prepare a meal, before you eat. And we always collect stool sample to see that you've cleared it up from your system and you're not a carrier like the famous Typhoid Mary. Okay, so one other side effect of using a lot of antibiotics is what we call C. diff. And this is usually seen overseas. So what they do, and it's something, if I tell you guys will start to laugh. So when you expose yourself to too much antibiotics, and you can get this C. diff infection. And overseas, what they do fecal transplant. They actually eat the feces to make good bacteria again in your body. Yeah, it sounds funny, but that's what's happening now because we're getting rid of the good bacteria in our gastrointestinal system. And when all those good the normal flora in the gut is killed off, then you can get this kind of infection. That's why it's always remember, be careful how you use your antibiotics. You don't misuse or overuse it. Okay, how many of you get really bad burning sensation in your chest, your epigastric, and you think, oh yeah, I might have gastritis? No? Nobody has ever had gastritis before, burning sensation? Okay. All right, so one of the bacteria that causes Ulcers in the stomach can cause this gastritic pain is Helicobacter pylori. And usually it's seen in the saliva, especially in the Pacific Island. They were doing some studies and they noticed that the kids were getting it, and they were trying to find out the modes of transmission. You know how the kids don't have teeth and then you want to mash the food, and you know some people don't have blenders. So how do the mothers feed their kids? Right, chew, and after chew, give to the baby, and that's how the transmission goes. So with anyone with Helicobacter pylori, we treat them with triple therapy. There's 2 antibiotics and a proton pump inhibitor for at least 7 days to clear up that H. pylori. And then we have worms. Anyone has seen anyone who sneezed and then one worm came out? Right. Good. Or someone coughing and the worm came out? Right. And how do these worms come into our body? It's our footwear. You're not wearing shoes, and this is how the worms enter into the body, goes into the gut, and then it goes to the lungs, and then when you cough, and then it falls into your food pipe and go to the stomach, and then the cycle continues. So once it's in the lungs, and sometimes they cough and sneeze, that's when the worm starts to come out. Yeah. And some of us have seen really big worms. And remember, if somebody is not gaining weight and all, then they will say, oh, that one there has hookworms because it's eating up the nutrition. But that could also be a sign. So you have to be very careful about footwear. Not just only for leptospirosis, but footwear for worms as well. And in page 206, it talks about which kind of medication to give for your worms. And then chapter 13 covers skin, muscle, and bones and joint infection. And this is one thing I wanted to emphasize on was cellulitis. So cellulitis is the inflammation of the skin covering your epidermis layer. And that's when it becomes really red and swollen. I'm sure some of you must have seen your grandmothers or elderly male who's immunosuppressed, they have this. So before we used to give penicillin Cloxa in our old guideline, but now fluoxetine is just as good enough to use as a single agent. Okay, diabetic foot sepsis. How many of us sitting in the room know somebody in our family that has diabetes? Raise a hand. Right, and they've done a step survey, and it shows that there's a increasing number of diabetes, and also some of our interns did a research, like 1 in every 20 hours, someone's getting an amputation. So the thing is with diabetic patients, the complication is that it affects their blood vessels and their nerves. And sometimes you have this what we call paresthesia, or what I think the Hindi word is like junjun, or in Fijian, nunu, you can't feel, it's numb. And when they get hurt, they don't know. Once it becomes really black and gangrenous and smelling, foul smelling, that's black is a sign of what? Death, yeah? So once it's black, that means that tissue is dead, and then you'll have to amputate that. So because of this diabetic foot sepsis, it is a polymicrobial. So it has a lot of bacteria, the anaerobes and the aerobes, gram-positive and the gram-negatives. Or just for everyone in the crowd. So anaerobes are those who don't use oxygen to survive, and there's aerobes that need the oxygen. Gram-positive is just the color of the stain, that they pick up the purple color or not. And sometimes if a diabetic foot sepsis is very bad, you need debridement. If not debridement, then amputation. Okay, then urine infection. So when you have a urine infection, is when you always want to go to the toilet and pass urine, or when you pass urine, it burns, it's painful. And there's the empirical and therapy is usually given. So you have to be very careful. Try not to give augmentin because it's too broad. And Cipro, please remember, it's precious. Yeah, what I talked about, Salmonella typhi, we need to keep that for our Salmonella typhi, because if it becomes resistant to Cipro, then we don't have any other antibiotics to help clear out the carriers. Pyelonephritis is when your urine infection. So your urine infection is where the outlet is, then you have your bladder, and then going up, you have your kidneys there. If the urine infection travels up to your kidneys, then that's what we call pyelonephritis, so you need, at least need 10 to 14 days of IV antibiotics. And then you have your STIs. There's different syndromes that you have, and you can refer to page 257 to 267. And if you're unsure, you can always refer your cases to the STI hub. Where's the STI hub in Suba? Anyone knows where? Yeah, near the bus stand. So if you have anyone who's got discharge, it's painful, or when they pass urine, or any sores down there, you can always refer your colleagues or your friends to the STI hub in near the bus stand. Okay, syphilis is a sexually transmitted disease. Usually this is a painless sore, and penicillin is the drug of choice. So we're very lucky they're not resistant to penicillin yet. But once they become resistant, then we're in big trouble. And there's different type of syphilis. Okay. Chapter 16 talks about TB. Anyone knows the signs of TB? Weight loss. What else? Night sweats. What else? Good. And when you cough, what comes in your cough? Right. So if you see someone who's losing weight, coughing a lot of sputum, there's blood in it, at night when they sleep, they're just sweating and their clothes is soaking with sweat, be suspicious of TB. And we have a lot of TB cases, and we have hotspots in Fiji. Hotspots in Fiji is Rambi, and there's some other different settlements that have that. And after COVID, we've been seeing a lot of cases of TB. Why? What happened during COVID, everyone? Right, lockdown, good. Everyone was in the homes, not going out. And whoever was infected with TB, then that's how we get it. Like we're breathing in all those MTB that's coughed out. So with TB, it's usually a 6 months treatment, and we have different drugs. But lately, we're starting to see resistance in the TB. And so we have to go on to our second line and all. Malaria, I won't really touch much on it because it's usually seen. Is it endemic in Fiji or not? Where is it endemic? Africa? Where else? Where in the Pacific is it endemic? Solomons, where else? Sawantok brothers and sisters, Solomon and Vanuatu. So if some of you are going to go to do your work, I know you guys work in different NGOs and all. If you're going to go to Solomon or Vanuatu, please take your prophylaxis so you don't get malaria. I think I'll stop here. That's about it. Any questions or comments? I know lunch is there, so everyone wants to rush. Okay, thank you.